Classic. All right, welcome and good afternoon, and welcome to this live stream with myself, Ruth, from Top Schools. But you don't just get me tonight. We have a special guest. So just before I bring on our special guest, thank you for watching live. Thank you for watching on replay. If you have any questions regarding international schools, particularly today, because of our special guest, we're able to take questions on individual learning needs. So our topic this evening is autism in girls, signs, symptoms, and underdiagnosis. So let's crack on. Thank you for your questions related to schools. I will definitely get on to them, but let's welcome Dr. Andrew Adler, clinical psychologist. Hi, Andrew.
Hi, Ruth. It's good to be here again on another Facebook Live. I think it's been several years since
It's
we've
been
done
a
one
couple of
together.
years. But yours is on YouTube. It gets lots of watches. And so we know that people watch on replay. So thank you. Thanks for staying in the office late.
It's my pleasure. It's always my pleasure to talk with you and talk with people who have an interest, certainly in their children, especially children who are perhaps different and have special needs of
Right.
a variety of different kinds, and how they can thrive and prosper both educationally and socially in school.
And we got to know each other, I think, was it professionally first or personally? Because my daughters worked with you. So I'm not sure which came first. So why don't you start briefly? Just tell us a little bit about yourself and your
I'm
practice.
glad to. Self-promotion is always good, so be glad to do that. But just so people have an idea who I am, that I am a licensed clinical psychologist in the U.S. I've been licensed for about 20, it's a long time, about 20 some odd years, 22 years. And I received my PhD in clinical psychology from Yale back in the late 90s. And since then, I've worked mostly in the US, in the New York City area, mostly with children. There was a while that I was just working with children ages 0 to 5, which was a wonderful experience. Other times I worked with children in psychiatric hospitals, outpatient clinics. I've also worked quite a bit with adults as well. Here in Hong Kong, I've been here for almost 7 years. So hopefully we'll become a permanent resident soon and even further integrated into the community. I've had my own practice for about 6 years, and I work with all kinds of clients, but I specialize in children, both in their assessment and therapy, and work a lot with their parents. And the areas I specialize in, which we'll talk about today, is autism is one of those areas, both the assessment and treatment. Of course, I work with a lot of students who have ADHD, students who have problems with anxiety, especially social anxiety, which is something that's been really underdiagnosed. We can talk a little more about that later.
Andrew, I know you've been in Hong Kong for 7 years, but I've been in Hong Kong for like nearly 30, so I feel like sometimes I've lost touch. But do you think, I mean, what's different about the families that are coming through your door in Hong Kong as compared with, say, the US or other places that you've worked?
Of course, in the US, I worked with many families that experience many kinds of stressors. So from a family perspective, I think Hong Kong, I won't say Hong Kong is unique because I don't know the entire world, but I think the one thing about Hong Kong is that the experience here, and even though my children are grown up now and don't live here and have actually and did not grow up here, what I can say is that the environment, the ethos here, if you want to call it, is so hyper competitive. You're smiling, and you know that, Ruth. And
well, I wondered if you were going to say, stressful, but you said hyper competitive.
People are comparing themselves with other people all the time.
Yeah.
All the time in so many different ways. I
I
mean,
mean,
we
I've
could just
been,
talk about things academically and socially among children. People,
yeah.
parents, talk with me about how they compare themselves. Whether they think they're doing a terrible job because their child is not at the top of his or her class,
Hmm.
even though he or she may be doing very well.
Yeah, I mean, I've been hanging out a bit in the UK a bit more recently, and I'm definitely sensing it's different there as well. And so the competition, um, but we could talk about so many things.
Mhm.
We are here to talk about autism in girls. So let's spend maybe 15 to 20 minutes. And then if you have
Sure.
any questions, I can see some questions coming in.
Mhm.
Thank you for me, I think. If you've got questions for Dr. Adler, if they're not related directly to autism, if they're related to any sort of social anxiety or ADHD or anything that you might want to have a chat with a clinical psychologist about publicly, then type your question and we'll put it to Dr. Adler. So autism in girls, you suggested this topic to me. Why?
Why now? And why now? Why now? And I'll talk about that actually. Actually, let me begin by talking about that. Um, Two reasons. I think the main reason is that there's been a lot written in the popular press. And these days, of course, we get a lot of our information from the internet. There's been a lot of articles, blog posts, posts in places like Reddit. I don't go to Reddit, but apparently there's a lot on Reddit.
I don't
Too
go to
much,
Reddit.
too
Yeah.
much, I think, from what my clients tell me about autism in women, in adult women in particular, and
Okay.
stories about women who have suspected that they have met the criteria for autistic spectrum disorder, which is the formal name that we typically use for autism. So
Yeah.
we call it ASD, autistic spectrum disorder for
Right. Are
short.
we allowed to call it autism? Because I feel like we need to say ASD because it's a spectrum, right?
That's right. That's right. It is certainly a spectrum, and autism is just the broad name,
Right.
but certainly it is a spectrum, and it's a complex spectrum at that. Taking a taking a step back just to look at what ASD actually is that again, this is based on the diagnostic manual that we use in psychiatry and psychology. That the core part of autism would be significant problems with what we
Mm.
call social communication. Well, what do we mean by that? Social communication are the skills needed to be able to communicate in social
Mm.
situations. Being able to engage in small talk is the perfect example.
Mm.
All need to engage in small talk. People on the autistic spectrum, to varying degrees, because it is a spectrum, have difficulty with that. You know,
Yeah.
they can't come up with the words, they can't come up with the ideas or thoughts, or something is blocking them from doing that.
Mm.
They may have difficulty, even though they may have friends, they can't express their feelings or their emotions. They may not be also aware of how other people are communicating and what the meaning is. So when we communicate, we infer what people say. People don't often say things directly, they say things indirectly.
Yeah.
People on the autistic spectrum have difficulty with that kind of inference. That,
Mm.
to be able to read someone's face, for example, when they say something. Sarcasm is a perfect example.
Mm.
With sarcasm, you have to read behind, you have to hear the meaning behind the words, that it's said in a way that is ironic or paradoxical. People on the autistic spectrum, again, to varying degrees, miss that.
Mm.
So that's really important because people are sarcastic, especially more in the Western world.
Especially
And
the Brits more than the
uh, we're pretty close in the. I think it's a different kind of sarcasm, but yeah, in the U.S. we can be quite sarcastic as well. Um, so that's one thing. The other major quality is a rigidity, or in terms of the way things need to be done, restricted patterns of behavior or interests, like a hyper focus on a particular activity, and distress when someone can't engage in that activity, for example.
Yeah. And of all the children that like I've seen over the last like dozen years or so, I can't recall a girl being diagnosed with ASD. I might have missed one or two, but they're overwhelmingly boys, right?
That's absolutely right. Almost exclusively. Now, I've, since being in Hong Kong, I have diagnosed maybe one girl on the autistic spectrum, and, well over 50 boys. And that's probably a typical ratio.
So why is that?
Okay. So that is sort of the crux of what is being discussed in various forums on the internet, mainly, and sometimes in the popular press. So there is a belief, and there is some research to support this, that those symptoms that I talked about around social communication and this kind of rigidity or restricted range of interest is also present in girls. But the main reason why we don't pick it up is that girls are better at masking or disguising themselves, so we don't see those problems.
Interesting.
They have a lot to do with socialization. Even though things are changing in terms of how we parent, there are still gender differences in how we typically raise children. Girls are taught to, there's more of an emphasis on the girls being polite.
Yeah.
I don't necessarily agree with all this, but that's how children are still raised, being polite, more respectful, being able to engage more in conversation. So I think girls are probably given more of the skills, or they have role models or are trained to be more social. So what happens in the beliefs that are now emerging around autism in girls is that girls learn what they need to do to be social to get by, but it's like they're putting on an act, or a mask, like a drama. They're expected to do that, where boys are not. So that's one of the reasons why it's often missed. Also, just the nature of the problems that we see in boys and girls. Girls tend to keep, we say, internalize things more. The problems tend to be more around things that happen internally within their mind. Boys tend to act things out more in their behavior. So behavior gets more attention. Behavior problems get more attention than problems like depression or anxiety. So we see much more ADHD in boys than girls.
Is that right?
Yes, quite a bit more. I can't remember the statistic, but quite a bit more.
Okay.
I think we're getting better at observing it in girls. It tends to take on a quieter presentation. You don't see it as dramatically in girls, but generally, it's the disruptive child who gets the attention. It's the disruptive child who gets the attention, and then gets assessed. Generally, I'm generalizing obviously here, but that is generally the case.
Yeah. That's
So
interesting.
That I think makes it hard for us to see that in girls.
So you brought this topic up. So obviously there's some new research that you're reading around this that's coming to the fore now. Does that mean, I mean, are you looking at some of the girls that you've seen in the last few years and maybe having a rethink about their situation?
Yes. And some of these girls I always suspected were on the autistic spectrum, but now with some of the research out there that has, and I'll explain more in a few moments, that has looked at some of the early signs, that I'm now more sure that these clients are on the autistic spectrum. I'll give some examples in a little bit. One of the things that's come out and that I can see in some of the clients that I've just mentioned, is that parents, when you talk with them, even talking with the parents of adults, will say that their daughter really seemed very different from other children. That might be in that they were detached from others. They had difficulty forming relationships. They acted okay. They acted fine. They got along with others. But they really never engaged fully in relationships with other kids. But because they were quiet, they followed directions, they didn't cause any problems at home or at school. Parents thought, well, children might be a little bit shy, but she's okay. So often you hear stories like that, and that's actually been studied and showed that an adult diagnosis of ASD in women is related to parents' reports of this kind of social interactions when these girls are much younger.
So this might be a good time to go to Sam's question. Can this masking become such a norm that it carries over to adulthood and then it just becomes part of their personality?
Excellent question.
Thank you, Sam. Hi, Sam.
Hi, Sam. That's a good question. Absolutely, yes. I could go on give a long lecture on this, but I'll give you the short version.
Yes, please.
Sake of not losing too many viewers here, our Facebook participants. When we talk about these diagnoses, we're talking about descriptions of the way people act, think, and feel. They are medical diagnoses, but they differ quite a bit. So psychiatric diagnoses such as these, or developmental diagnoses, in those categories are descriptions of what we observe and what people tell us. Different from other medical diagnoses where you can locate a part of the body, or you can do it or do I must say a blood test, a CAT scan or whatever, a biopsy. You can identify something. We can't do that. We don't have that. We have our observations and what people tell us. And you can imagine that there's a great deal of subjectivity and disagreement in how we as professionals might see one person versus another professional seeing that same person as well. So I want to keep that in mind, because certainly someone who has these kinds of social difficulties at a young age may have developed a more sort of way of acting as an adult that makes that person hard to be able to relate to others socially, or they develop a particular way. So let's say take avoiding personality disorder, avoiding meaningful, or sometimes depending on the severity, almost all social interactions. You can imagine someone at a young age not having the skills to really engage in meaningful interaction socially, then later on developing avoidant personality disorder. Later on, somebody might see it as autism continued. Other people might see it as a personality disorder.
But it is such a grey area, though, isn't it? Even in children. I mean, at what point is it beneficial to have a label?
Say that again?
At what point does it become beneficial to have it labeled?
That is a great question. It depends on the person.
Depends, yeah, 100%. We've got lots of questions coming in. Oh, sorry.
We should address some of those, actually.
Should we do that?
Topic.
So, thank you for the questions. If I'm in a different software, if you don't allow the software to see your name, I'm sorry that I don't know your name. But let's go with this one. So, YC Choi, what are the typical signs of ADHD in a 5-year-old? And I can answer the second part about what can we do to assist with going to school. I wonder, would you want to take that first part, Andrew?
Yes, let me take the first part. Okay, So those would be similar to those you'd see in boys. But as I mentioned, we say it's a quieter presentation, perhaps not as pronounced in girls as in boys. So when we talk about ADHD, we're talking mainly about problems with attention and concentration and being able to deal with distractions. I can go into a lot of depth on this, but those are the core characteristics. So we often see that when students start primary school, when especially within the international school system, when work becomes more challenging, or academic work is actually introduced, there is more of a demand to actually pay attention to what goes on in class. So the kids who are not paying attention to looking out the window, they seem to be lost in space, in their own heads, for example. They get distracted by somebody just holding or playing with a pencil. You see that repeatedly, you start to suspect the person may actually meet the criteria for ADHD. Again, with girls, you don't see it as quite as pronounced, but I've seen many girls over the years who you dig a little bit deeper, you find that they have these difficulties. The hyperactivity part, you usually see in much younger children. You typically don't see that often when a child gets to primary school. Right. It is part of the name of the disorder, but it's typically the hyperactivity is more with younger children up to age 4 or 5.
Before I get to the second part, Andrew, I find myself talking to parents every day who mentions ADHD. It seems so common. Can you talk a little bit about, is it more prevalent than it used to be? And if so, what are the potential reasons for that? And YC Choi, I'll get to the second part of your question after this.
We don't know.
Okay.
It's hard to know and do research in this area because this is the real world. And you can't really do this kind of research and get real answers in the real world. We're not in a laboratory. We can't control everything that's out there and say, okay, we can take out this factor or that factor. It's so hard to know. But based on experience and what people have theorized, that both are true. We are better at diagnosing it and catching it at a younger age. Attention-related issues, and there's a lot more to it than what I'm talking about. But attention-related issues, we are catching it at a younger age. Therefore, obviously the number of children with ADHD is increasing, and adults too, by the way. At the same time, there are probably factors within the world that are increasing the prevalence of ADHD. I think we can a whole discussion about the use of devices, for example, that are enticing, that are rewarding, that draw kids with ADHD pay great attention oftentimes to whether it be video games, YouTube, social media. They can do any of those things for hours, whereas they can only pay attention for 3 minutes when it comes to doing homework or paying attention in class. And I get and that becomes more rewarding. So you find that kids are gravitating toward that, and they're perhaps not practicing or learning their attention skills as well as they used to.
Interesting.
One factor.
Yeah. At what age do you diagnose ADHD?
Well, you can diagnose it actually at a very young age. I mean, I've diagnosed kids as young as age 1.5 to 2. What you need, not so much in Hong Kong, because I don't see the kids that young. I wish people would bring in their children at a young age, but more in the States. And what you want to see is that if there's a demand to place on a child, in other words, there's an expectation that the child's going to need to do something. That could be a simple task. How well does he or she attend to it? For example, eating a meal. Now, we're not going to expect that a 2-year-old is going to sit at the table for half an hour and eat a meal. But you would expect they would sit there for a few minutes and eat before just losing attention and staring out into space. So, it's more difficult at a younger age. Typically, we will diagnose it when a child starts primary school or elementary school.
Then it becomes
academic demands start to really pile on.
That's when the teachers will start mentioning something, and then the parents. I mean, the second part of YC choice question, maybe I can take this. I'm assuming that your child is already enrolled in an international school, if they're 5, and maybe you're starting to see that maybe she's struggling a little bit, or maybe the teachers have said something. I mean, most of the international schools, and correct me, Andrew, and we've worked together for a long time, but
Mhm.
I feel like most of the international schools have some capacity, a decent capacity to accommodate mild ADHD.
Mhm.
If the child is already enrolled. And so what should they be? I mean, if your daughter is already diagnosed, then you should have a full psychological evaluation, right? That the sort of reports that you write, which run
I
to
would
like,
say we'd call it a psychoeducational assessment, because we want to look at,
yes,
even at the beginning of primary school, we want to look at intellectual functioning, what the abilities are,
yeah,
child. We want to look at, even at the beginning of primary school, what are the early reading skills, writing skills, early math skills,
yeah,
and is a relationship between problems with attention and academic
right.
performance.
And so those reports that you write, they run to like what, 25, 28, 30 pages, something like
I'm trying
that.
to write less than that these days because nobody reads that much.
Well, and we've also had discussion about, a report for the parents and perhaps a slightly different report for the school. But okay, he's just updated. Let's see what.
Okay.
Interesting to understand the signs not yet enrolled. Well, if you're attempting to move into year 2 in ESF, I think you've got potentially that's going to be tricky. So, well, look, if she doesn't have ADHD, and if there are no issues, then count your blessings. Just try and get into a school first. I think let's not worry about the things that haven't happened yet. But I think maybe because everyone's talking about it all the time, right? So maybe we want to
The,
look
the
to our
prevalence
children.
is quite high. I mean,
Very high.
there are quite a few kids in every single school. Um, I would not say that I would not discourage a child from applying to a school because a child might have ADHD. I think it needs to
No,
be
I mean, I
assessed
think
and
if
addressed.
it needs to be what? Sorry.
Assessed and then addressed.
Yeah.
And hopefully the schools would see that a child is doing that. Now, I can't speak for the schools, but I would hope the schools, I can see you grimacing a little
Yeah.
bit. Uh,
It's a tricky area. I mean, mainly what we see a lot of is that the children have gone in for the assessment, and there's clearly something. They're struggling. There's an issue. There's something, and because the parents haven't disclosed, the schools would they need to understand what they're dealing with, right? So they need to understand that, okay, we can see that this child might have some needs. What are those needs? And without the backup of a psychoeducational evaluation,
mhm.
the school is they're working in the dark, really. So they rely on experts like yourself to inform as to what the child would need in terms of what extra support the school can provide, right?
I absolutely agree with that, Ruth. And um, just to maybe emphasize that point even more strongly, from what I have heard from parents over the years, that if you suspect anything, whether it be ADHD or anything else in terms of one's psychological functioning, social, emotional, behavioral functioning,
Mm,
please see a professional to have that assessed, even informally and then maybe formally, because schools will pick up on things during the interviews or during even if they're not even talking with the child, even if the child is taking a test, they'll observe,
yeah.
and it's better to address whatever there might be beforehand and have
It's
a
better
proper
to know, right?
and then even take some action before you even apply as
But
well.
do you think that there's a risk of, if you have a very, very, like, parents worry all the time about
Mhm.
things, right? We all worry. Um, and if a parent has a slight hint, a slight concern that there might be something, and then they take them to see, maybe not yourself, but maybe some other, clinical psychologists out there. They're going to get what they pay for, and what they paid for was a diagnosis. So then they've got a diagnosis.
That's right. And then they actually have an obligation to tell the school.
That's right. So I don't know.
Well,
It's a tricky one, right? Can I
choose your
use your
professional
answer? It
carefully.
depends.
Choose your
Choose your
professional
psychologist carefully.
carefully.
Yeah.
Yeah, that's really important. It's a very difficult issue. I'm
It is.
positive there's not an easy answer to it. I mean,
Mm.
I've seen reports where there's been a complete, children being diagnosed with autism at a very young age. At age 2, we could do it at a young age. We have to be so careful.
1.5, 2, yeah.
I mean, just to give you an example, I was still actually working as a psychologist for a pediatric clinic in Shanghai. This was about 10 years ago. Yeah, about 10 years ago. And there was actually a family that came from Hong Kong, and they had moved to Shanghai, and a developmental pediatrician, a pediatrician who specializes in child development, diagnosed this just turned 2-year-old boy with autism. And so he was starting to get what we call occupational therapy to help with his motor skills and sensory related problems at the clinic I work at. And the occupational therapist asked me to come in just to observe this child. I looked at him and saw him interacting, and he was quite defiant, quite oppositional, as you expect a lot of 2-year-olds to be, who are trying to master their way in the world and develop a sense of independence, autonomy from adults, and especially their parents. And he wasn't making eye contact. But it was not because he wasn't interested socially, but because he was very self-directed.
Right.
He wasn't interested in relating socially. He was interested in doing what he wanted to do.
Okay.
And this pediatrician saw that as this child doesn't have or is not using his social skills to interact with others, where it really was age appropriate. And it took months and months to give me some parents. So it was actually very typical 2-year-old.
So choose your psychologist carefully, choose your timing carefully, and trust your instincts.
That's right. That's right. I mean, one thing is maybe you could sometimes do an informal assessment to see if there really is a need to go any further. And I do that all the time with parents.
Preliminary assessment.
Would observe a child interacting with me and also with his or her parents. And then we get an idea of whether we should go forward with anything further. There's been no diagnosis given. So at that point, you don't have to report anything to the school.
You still do, because they still ask you to tick a box. Has your child ever seen an educational psychologist, an occupational therapist, a speech therapist? It's a tick box.
Okay, so I have not seen the application, so I don't know. I thought it was that, has there ever been an assessment conducted, or has there ever been therapy? So even just going for one time, a one-off kind of assessment, that is so tricky, Ruth. And I can't tell parents to be dishonest, but it is a tricky situation, because you basically, what I do is more of a screening.
Yeah.
But that would be then construed by the schools, if you're being honest, as as a red flag.
Yeah.
And there may not be a red flag after I
see
the child.
Let's get, the questions are coming in. So if you do have a question for Dr. Adler, please go ahead and type it, and we'll get to it. Sorry, we can't see your name, but I'll be able to see that over on Facebook. 4.5, possible selective mutism. She doesn't want to speak to strangers. Yeah, this is common as well, right?
That is quite common, and is not is something that I think parents feel very guilty about, feel very ashamed about, and sometimes we don't see kids so they're a little bit older and the problem has existed for several years. You would not want to speak to strangers and
Yeah, suspected
So,
selective mutism.
yeah. So I would want to know more.
Mm.
This sounds like it might be either selective mutism or it might be what we'd call social anxiety. So what's the difference? Selective mutism would be not speaking at all or almost not at all in certain situations, in certain environments, very specific environments, usually at school,
Mm.
whether it be in kindergarten or early in primary school when we pick this up.
Mm-hmm.
And it's almost the point of the child obviously has the language skills, the expressive language skills to be able to speak, but doesn't. Usually, I mean, from what we understand, that selective mutism is a form of anxiety, and it's a fairly pronounced form, and it's a discomfort of speaking in certain situations. Child might speak absolutely fine at home to parents and other family members, but not in school.
Mm-hmm.
It could be in other situations, but it's usually in school. I would want to know more for this particular child.
But this
Is it
parent said when they're out, when they're out at restaurants and with
wages,
relatives,
for example? Would it
but they're
also be other people
strangers.
too?
Mm.
They go into a shop, for example, and somebody says, "Oh, hi."
Mm.
Child turn away or just stay silent or say hello. I'd want to know about other situations as well, because it sounds like it may be possibly more around the fear when an unknown person, a previously unknown person, is interacting with that child,
Mm.
not so much the environment itself.
So how can she help her to overcome this? She's going to interview this year and she's worried.
Okay. So, one of the things I might do, and again, this is somewhat generic advice because I don't know this particular child, so
Yeah, of course.
caveat there, is to go to places like playgrounds, which are wonderful places to meet other kids around who are still in kindergarten, and to gently encourage your child, your daughter, to go up to other kids and start talking with them. And the way you can do that actually is by modeling that yourself. Now, it might seem a little odd if you go up and start talking to a stranger.
Mm.
You have to pick your times to do that. That you're not going to get in trouble with that child's parent. Um,
Mm.
but certainly, you can encourage your daughter to do that. And even if she makes even the slightest effort, even the slightest effort to go up to another child, the writer here just mentions speaking,
Mm.
but I would say even interacting, but even trying to speak, I would
Mm.
praise your daughter for making that attempt.
Mm.
You want to praise whatever a child does in doing something that is approximating where we want that child to get to.
Right.
This is hard work. This is what
Yeah.
we do as therapists oftentimes. And when I work with parents to teach them to do that with their kids and support them in doing that, is to be able to praise, to reward. Praise, verbal praise is the kind of reward. Or it could be also physical. It could be patting on the shoulder.
Mm.
It could be a kiss. It could be a hug to
Mm.
show we are proud of what our child's doing. And that is experienced by most kids as something very powerful as a reward. The more you do
Mm.
that in these situations, like in playgrounds, um, in other situations, there might be kids around her age and family gatherings, for example, where
Mm.
your daughter might not know the relatives so well. And maybe with people of other ages too, since obviously the interview is going to be with an adult. Um,
Mm.
at least part of it would be, I guess. It could not just be with children, but could be in situations with other adults and family gatherings with family friends, to be able to encourage your child to do that. It's actually easy
Mm.
with adults because you can actually start a conversation with adults yourself as a parent, and then encourage your child to join in as they do. And then
Maybe
pray.
maybe I can add a bit on the end, because your daughter is going for interviews this year and you're worried about it. Um, I mean, presumably she's already going to kindergarten. So speak with the kindergarten teacher. If she is verbal and in an interview, and that she will, that you trust that the teachers are going to get the best out of her. Am I back?
You're back now.
Oh my goodness, my internet is so rubbish. When did I phase out? Shall I just go over that again?
Yes, please.
Okay. Oh gosh, how embarrassing on a live. I was just saying that if your daughter is happy in her kindergarten, and ask her kindergarten teacher about this, if she's happy to engage with her classmates and her teachers in school, then you're going to want to hopefully trust the process. And I know she's going to go to an unfamiliar school and meet unfamiliar teachers, but trust that they have done this a million times and they've met children like your daughter a million times, and that hopefully they can get the best out of her. I think that's really, she must be in K3 already, is she? Must be going to year 2. I hope that helps. We've got a couple of more questions. Let me see. Right, let me hide that one. Dum-de-dum-de-dum. Here we go. My elder son was diagnosed with Asperger's at the age of 6, and a younger son getting recommendations I should have him assessed as well. Not sure if at 4 the assessment will be accurate.
Yes. If it's obviously, if the assessment is done well, it would be accurate.
Okay.
I'll tell you why. Expression is not just verbal, it's not just for spoken words, but it's also nonverbal as well. So the kind of ways in which we communicate with our facial expressions, our emotions, the attention we give to other people, that doesn't have to involve spoken language. So again, when we're talking about social communication, I should also mention that it's nonverbal as well. So for example, if I throw a ball to say a 4-year-old, if I throw a ball and then go to pick it up, I would expect a 4-year-old to look at the ball as I throw it. As I go to pick it up, the child's going to look at me and see if I'm going to throw it again or do something else with it. That kind of movement of attending to what I'm doing is a kind of social interaction.
Mm-hmm.
It's saying, I'm interested in what you're doing. I'm interested in what you're doing. I'm not using spoken words, but I'm showing by my bodily reaction, my face. I'm turning toward you to see what you're going to do next. That's a form of communication. So yes, even though the child may not be expressing himself using spoken words, we can see that non-verbally.
But are you able to diagnose autism, or would you say that what's the clinical expression that I've seen on these reports, that it might be autism?
I would be more definitive than that. I'd say the child either meets the criteria or it doesn't. The child might show characteristics. I would say that,
yes.
but I wouldn't be wishy-washy about it, to be quite honest. I've seen too many reports of people who are wishy-washy. It doesn't help anybody. You meet the criteria or you don't. It's somewhat, again, everything's on a spectrum in this world. Everything's on a scale of non-existent to severe, right? So when we say somebody meets the criteria, that they've reached a certain threshold in terms of the severity of the symptoms, and also whether the symptoms really affect a person's everyday life. The symptoms affect everyday life, and that is something that we can say. We can't be absolutely definitive, but we can be fairly definitive. If I am not sure, I might diagnose them as saying, I'm diagnosing, but I do so with some caution.
But I just noticed that this parent has not indicated that the younger son, aged 4, is displaying any traits that he suspects that he may be on the spectrum. So I wonder if that might be, if he's not, I mean, if he's not they should know, because they have the elder son who is diagnosed. They should be familiar with some of should be recognizable. So if there's nothing obviously obvious with the younger child, why would they then go to get him assessed?
Couple responses. First, we don't even know if
No.
Again, I don't mean to be cynical, but I will be. I don't know if the Asperger's diagnosis, and by the way, Asperger's is an outdated term. We don't use that
Yes,
anymore.
must be a local CP, right? Local clinical
Yes,
psychologist.
we don't live we don't know if that's an accurate diagnosis or not. I have no idea.
That's true.
I have no idea. I would not. I assume nothing.
Yeah.
But let's say assume for the moment that it is an accurate diagnosis, that the child is on the autistic spectrum somewhere. And you're right. If that's the case, then the parent would know something. It says also that I'm getting recommendations. I don't know if it's from the school or from the kindergarten or from somebody else, or from somebody from some activity that an adult who runs an activity the child's in. But let's assume it's a kindergarten. I'd want to know more. So, for example, so if somebody comes to consult with me, we're not doing a full assessment, but they come in with the decision that the school has said, well, we think the child might be on the autistic spectrum. Or they're saying we have concerns. They really shouldn't say we think the child should be on the spectrum, although I think a lot of schools would say that. But they should say we have concerns about how your child is doing socially, and maybe also in terms of his speech and language skills. I would want to know more.
Yeah.
Well, about how that child is doing at home and other situations. I might even want to talk to the teachers before doing a full assessment.
Well, to that parent, if you would like to message me or Dr. Adler, then maybe we can have another deeper chat. I mean, it's so specific to each individual child, isn't it?
It certainly is.
I think those are all the questions that we had for now. Couple of repeated questions. So we've had ADHD, we've had autism, selective mutism. Oh, here we go. And there's a couple of questions for me about sort of general school admissions and stuff like that. Shall I do those in the middle? And then if you've got questions for Dr. Adler,
I will remain and stay here. And
you okay to hang out for a bit? Got nowhere else to go?
Always love to hear your wisdom, Ruth.
Oh, well, I don't know about that. Let's have a look, shall we? So many questions about ESF. So we are in application season. This is September, and boy, are people panicking. So my child in ESF is applying to ESF primary from another kindergarten, and she's a foreign passport holder. Do I think you have a chance? I'm sorry, I have no idea. What can we do to have a higher chance? We've applied to ESF kindergarten before, but we're not offered a slot. Right. The thing is, there are plenty of schools in Hong Kong. Okay, there are some great international schools in Hong Kong. If you have decided and you have done ample research and you are convinced that ESF is a good fit for your child, by all means apply. But there are no guarantees in life. And it sounds like you don't have any priority. So don't put all of your eggs in the ESF basket. I'm sorry, I have no idea how I can suggest that your child might have a higher chance because I don't know you. But ultimately, even children who appear to be a perfect fit, there are too many applicants for the number of seats available. So I hope that just look elsewhere. There are some really great options in Hong Kong. Okay. This is a long one. It's going to cover most of our faces. Oh, hello, YC Choi. You're very prolific this evening. My child is a foreign passport from the Netherlands. Okay. No, we do not have the Dutch curriculum. Now, I think earlier, let me track back. You said your child is 5. So thinking about what your child might do at university, who knows? Who knows? Who knows where we will be, if any of us will still be here, whether or not universities will still exist in their current form, nobody knows. So the first thing I would say is, please choose a school for your child, for your 5-year-old child, for now and for the next 3 to 5 years. Because beyond that, who knows? You'll have a different child. And so I don't know the Dutch university system, I'm afraid. You were offered year 1 last year, but withdrew. I wonder, are you regretting that now? I'm just going to spend a couple of minutes on this, right? I've seen a bunch of questions. We've got this chat now in the Facebook group, the Successful School Admissions. And I think there were 3 comments today and yesterday. And it's still ESF, but it could equally apply to any other international school. You would prefer your child to stay in K3 to get more Cantonese and then apply to an international school after K3, which is late. So that means your child's applying for year 2. This is going to reduce your chances significantly. And what then is the benefit of an extra year in a Cantonese kindergarten? How much will that really impact your child's education and life going forward? I don't know. But if you have a Cantonese household, does your child need to be in a Cantonese kindergarten? From the perspective of strategic admissions and successful school admissions, we recommend that you apply to the school when there are the most number of places available. In ESF, that's K1 and year 1. So applying for year 2, make sure that you apply to other schools as well. Yes. Okay, those were the cool. Any other questions for me or for Dr. Adler? Did we cover our topic appropriately? We talked about autism in girls, signs, symptoms, and underdiagnosis. So if there are parents out there with daughters and they might be thinking that there might be some signs or symptoms, what should they do next?
Well, I think come to a psychologist like myself or a developmental pediatrician. Of course, you have to vet everybody first, as you said earlier, Ruth. And before launching into a full assessment, if you're not sure, or it's not being required or highly recommended by a kindergarten or a primary school or even secondary school, then come in for a consultation to get an idea whether it makes sense to proceed to a full assessment.
Yeah.
And that's an advice I'd give for any kind of concerns. Obviously, going well beyond possible autistic spectrum disorder.
Yeah. What are the other sort of common diagnoses that you're giving out?
I would say social anxiety is a huge one. Anxiety more generally, but social anxiety in particular. Depression is something that is really difficult to diagnose in children, but is quite prevalent. Children don't have the cognitive or language skills to be able to express things the way we do as adults. They often express things through behavior or withdrawing from other people. How we interpret that is so important. So I look at, when I do an assessment, a full assessment, I look at a wide range of sources of data, including what parents say, what children say, my observations in the classroom, my discussions with teachers, rating scales, multiple rating scales these days, and pull that all together to try to understand what's going on. Depression is one of those ones that's very difficult to diagnose in children.
What age are you seeing children being diagnosed with depression?
Probably not till primary school, though I suspect it exists at a much younger age. I think it's just so hard.
Oh, it's so hard to be a parent these days.
So hard to to.
So hard to be a parent. I mean, so hard
Oh,
to
it's
be
very difficult.
a
But the
child.
imperfect parent is a great parent. We know that imperfect role models are the best role models. There is research on that. You don't have to be a perfect parent. You need to be
Yeah,
imperfect. You need to acknowledge your imperfection.
embrace your imperfections, right?
Exactly.
We
And
are all
acknowledge
perfectly imperfect. I think Lady Gaga had a song along those lines.
you more contemporary than I am.
Slightly, just slightly. Um, I mean, yeah, it's a minefield, isn't it? One more question from our star participant this evening. I'll find a prize for you. YC Choi.
Ah, okay. That
Critical
would
question.
for a full assessment for a child, it's going to range anywhere from 18,000 to 26,000, and it depends on what needs to be done for an assessment and what we can do.
Yeah. And I've seen reports, I've seen a lot of your reports because we work together, and I've seen reports from different psychologists that sometimes 2, 5, or 10 pages. If you're applying to an international school, I wouldn't recommend these brief reports. They seem to be a bit brief. And
And
yeah, go ahead.
in a related way, I also would find out what the psychologist is actually going to do.
Yes, what tests are they going to run? So do you
So,
have some recommended, yeah, what do you do then?
so I actually, when I make contact with a parent, I send out a, a summary of the whole assessment, including the tests that I would use. So, for example, for intelligence, which basically intelligence is the capacity to be able to learn in school academically.
Mhm.
So these are kind of like the building blocks of academic development. So for that, we use something either called I use something called the Stanford Binet, but the more popular one, which I don't think is quite as good, but both are acceptable, would be the WISC
The whisk, yeah.
5 at this point. Um, and then for achievement, the one that I use, which is the most popular, which is the Wyatt 4th edition. It's probably or the Woodcock Johnson. Both are excellent. The Wyatt's more popular. Doesn't really matter.
Would you be able to give us sort of a list of the tests that you run? Would that be okay? And then we can share that
I
later
certainly
on.
can do that.
Because I think that is, definitely there are psychologists that are doing these sorts of reports, and they do range. So it's a really good point to check what tests are going to be covered. And there might be alternates, right? But they should be testing for this or that or the other.
You should stay
Really,
away
really
from anything that seems too out of this world, like any special, I don't know, any special kind of devices that are used to measure brain waves to try to come up with diagnosis of ADHD. That stuff is nonsense. It's quackery.
I mean,
Absolute quackery.
yeah, and there are online quizzes nowadays. I keep getting them popping
Okay.
up because, yeah,
I get lots of referrals.
yeah,
People refer themselves, usually adults, but
yeah.
sometimes they're kids, who take a test online and say, "Oh, I know I have ADHD. I know I'm autistic." These tests are not validated. We don't know of any research that backs them up. Anybody who spends the time and money to develop tests is not going to give it for free. If it's
Yeah,
for
it's
free,
nonsense.
you have to vet things very carefully.
Yeah, you do
And
have to be careful. Yeah.
everybody will meet the criteria for whatever. Too many people, what happens is that there's an overabundance of people coming up as positive for ADHD or autistic spectrum disorder. The good news is that when people come to me, whether they be children or teenagers or adults, usually there's something else going on. It may not be what the test indicates, but there's something else going on. So the assessment is still worthwhile.
We should actually, I've just remembered that we've kind of missed off a bit, which is once there's a diagnosis, let's stick with ADHD for a moment. Once there's a diagnosis, yes, there are some there are accommodations that the school can make, and there are sort of practices and behaviors that you can suggest and habits that can be formed or broken. But there's also medication, and that's a bit of a rabbit hole, isn't it?
That's right. Good news and bad news, I guess. The good news is that for ADHD, medication, if done carefully and thoughtfully, it can be very effective in just improving attention span, especially in school. The bad news is that that's really what works. There isn't a lot one can do behaviorally in terms of therapy, in terms of school interventions to improve that. There's some basic things that you can do, like, for example, a child can move closer to the front of the class.
Yeah.
So that the child has fewer distractions around him or her. The child could be paired with a student who has a good attention, so the child has a good role model. But to really address attention, medication really does work wonderfully. You want to find another whole issue, finding a good. There are some great psychiatrists here. There are some. Most of them psychiatrists. I'll be honest. I would not go. I would not send an enemy to any of them. I mean, they just spend a few minutes with a patient, and then they have a diagnosis, and they walk out with a bag of medications. And, it's not helpful. But there are some great people here in Hong Kong. Wonderful people, better than people I worked with in the U.S. The other thing is that therapy and other kinds of interventions in school can be helpful with things that are related to attention. For example, like organizational and planning skills. That's a big one. People with attention also have problems with planning and organization. We call those executive functioning skills. There's a lot of brain science research on this. So therapy, and I do work with a lot of kids who have organizational and planning skills, whether it be planning and organizing their materials that they need for school, or planning, for example, to do assignments and how they pace themselves, and especially with high school students, but also with primary school students, being able to plan for projects. Other things as well, like short-term memory. There are also issues with getting started, being motivated to begin tasks, to be able to finish tasks. There's a whole wide range of areas that can be worked on in therapy that relate to attention.
Yeah. We've got, I think this must be the same parent talking about selective mutism again. How can a child with SM be diagnosed if she doesn't say a word at all?
Okay, good question. So, if the child's not speaking in any environment, that would really concern me in terms of, is there a fundamental speech and language issue? I might involve a speech and language therapist in doing an assessment. If the child speaks a little bit at home, and let's say not at school, which is typically what we find with children with selective mutism, the way I would assess it is to observe the child in school. And be in the background. Obviously, not let the child know that I'm there to see him or her, and observe. I wouldn't observe at home, because child would know that something is different, than somebody else a stranger is coming to the house. That might change things considerably. But I would base it on parent report. But if not saying a word at all, that part gets me.
I think again, this comes down to trusting the process. Trust that you as a professional, or the teachers, that they know how to work with children like this. So
that's right. That's right.
Yeah, trust the process.
And trust someone who's not there just to make a buck. Just okay, your child needs an assessment. I want to know why we're doing an assessment. Am I the best person to do it? And if I am the best person, what's the way that's going to be most helpful in understanding and helping your child?
Yeah. We're going to have to wrap this up, because we've gone on for over an hour. Who would have thought? I usually do these for about 30 minutes. So thank you so much, Andrew. It's been great. This will be, if you are watching this on replay, will be up on YouTube, and it will live on Facebook. And we'll put your contact details in the comments below as well. So
thank you so much, Ruth.
Thank you so much. Thank you. And
Okay.
then just before I end, I think next week is the 14th, right? I've got guests lined up for the next couple of weeks, which is really exciting. So have a look in the Facebook group in the events section, and I'll be posting about next week's guest and the guest after that very soon. And if you want to reach me, you know where to find me. So thank you for tuning in. I've been Ruth. My guest, Dr. Andrew Adler,
Thank you,
clinical
everyone. Thank you,
psychologist.
Ruth.
And I'm going to say over and out. Good night and thank you.
Good night, everyone.
Bye.